Well, hello, everyone, and welcome to today's sponsored webinar, Beyond the Bucket Brigade, Strategies for Behavioral Health Management Across the Continuum of Care. My name is Rhonda Fisher, and I am the Clinical Program Lead for Team Training at the American Hospital Association, and an ER nurse by trade, where we in the ER have a lot of intersect with behavioral health, so I'm really excited to hear what our speakers have to tell us today. We're extremely honored to have Array Behavioral Care sponsor today's webinar. As a mission-driven organization, Array aims to transform access to quality behavioral care services through the innovative application of technology. The Array team is motivated by a vision of a world where loved ones never struggle to access behavioral care in support of their wellness. That's a mission we can all resonate with in the year 2023, that's for sure. So before we get started, just a few rules of engagement to highlight. You can access audio by listening in through your computer speakers or through your phone. Please note that you are in a listen-only mode. If you're having issues, you should be able to access the toolbar at the bottom to switch to either phone audio or computer audio. Please note that this webinar is being recorded and will be made available on our website. Slides were sent via email this morning, so you want to take a peek there if you haven't seen them yet. Throughout the webinar, if you have any questions for our speakers, please enter them in the Q&A pod, which you can find at the bottom of your screen in the Zoom toolbar. I'll do a moderated Q&A session at the end with our panelists. And if you have any technical questions or comments in general, feel free to put those into that Q&A pod as well, and we'll help you out as best that we can. Whatever goes into that chat pod will not be included in the recording. Finally, after our webinar is over today, we'll have an evaluation that will pop on your browser. We really value your feedback, and so does our sponsor, so please take a moment to complete it. So with that, I'd like to just quickly introduce our speakers today. First, Dr. Jamie Evans. She is the Medical Director of On-Demand Care and Clinician Engagement at Array. She's double boarded in family medicine and psychiatry and also holds a master's degree in public health from the University of Michigan with a concentration in health behavior and health education. She retains professional interest in psychiatric crisis work, psychosomatic medicine, as well as in maintaining a passion for mentoring students interested in healthcare. Dr. Leroy Rinovar is the Medical Director of Scheduled Care, At-Home Care, and Clinician Engagement at Array. He's a double board certified psychiatrist specializing in child, adolescent, and adult psychiatry. Dr. Rinovar was honored to be featured on the Texas Super Doctors Rising Star list that is reserved for healthcare providers who have attained a high degree of peer recognition and professional achievement. Congratulations, Dr. Rinovar. And then finally, Scott Baker is the Vice President of Sales at Array. He has worked in the behavioral health industry since 2012 and focused his attention on identifying and innovating the latest opportunities for improving care via telehealth. He frequently shares on telebehavioral health trends, applications, and best practices at speaking engagements across the United States. So thank you for joining us, everyone. We have a very exciting program for you today. And Scott, take it away.
Thanks, Rhonda. Thanks to the AHA for hosting us. And thanks to all of you for jumping on and spending an hour with us today. What's with the title of the webinar, right? The Bucket Brigade. When was the last time anybody even considered what a bucket brigade is? And certainly this strategy for firefighting predated my era, probably all of our eras. But the idea here is that the bucket brigade is it's a line of people, each of which is stationary, and we're passing buckets of water down the line, starting at a reservoir, ending with a splash on the water. How does this relate to managing behavioral health care across the continuum? That's my job and Dr. Leroy and Dr. Jamie's job here today. And so we're really aimed here to talk about how do we get beyond this concept of a bucket brigade? What are the strategies for connecting the points in the continuum of care and managing the scarce resources that we have for optimal outcomes? So if I may, grab your bucket, flip it over, have a seat, and let's get on to it. I feel like all of these presentations start with statistics. How many of these statistics are you guys already familiar with? Probably a lot of them. But which of these are the bucket in the bucket brigade? Which are the water? Which of these represent a person in the brigade, and which ones of these are the fire itself? So let's start here with a very common statistic that's shared to demonstrate the current condition, which is more than half of counties across the country don't have any psychiatrists. So that would suggest more than half of the counties in the country don't have any water to put out the fire, or the brigade is longer for the patient to reach the fire. In these counties, the fire burns hotter, it burns longer, and it causes more damage. The same is the case when we consider the psychiatrist shortage, the incidence of behavioral health. That number here, 1 in 3 Americans will have mental health or substance use issues this year. Who remembers when it was 1 in 5 before COVID? These all demonstrate not having enough water in that brigade to put out the fire. And frankly, I don't believe that we're getting any more water anytime soon. Let's look here to the 3.2 times longer wait line time for behavioral health patients in the ED. That's a person in the bucket brigade, right? That's your hospital, your ED physician, your emergency department that's standing there waiting for water to be put in their hand, a bucket to be put in their hand to splash onto the fire. I appreciate you bearing with me here on the metaphor, and thanks in advance because we'll keep it live here throughout the presentation. But we have to consider as we move through here, what is the impact to the patient? What is the impact to each point along the continuum of care? And how is the entire system affected when we consider the current state of behavioral health and we move towards considering and enabling the optimal state? So let us consider here counties without psychiatrists, for example. Look at that from a patient perspective. A patient with, first behavioral health diagnosis, considering where do I go for help? And what happens when help is delayed? Think about that same concept from the system perspective. When help is delayed, then the fire spreads, right? The fire smolders. Where else might this patient go? How else might they present? And how does that affect the rest of the system that's dealing with scarce resources and having to determine where do we send the bucket, where do we send the water next? So we're setting the stage here. Behavioral health care does not occur in a vacuum. We deal with pockets of resources that are rarely enough to address the problem. We have to consider, how do we hand off the buckets in the bucket brigade? How do we hand a patient off? How do we hand resources off? How do we coordinate from one setting to another? As we go through here, the strategies will become apparent. There is a wrap-up slide at the end, but the goal here is to equip you with perspective and strategies as we go. But the overarching idea here is that the more we do with the water and the resources when it is in our hand, the better we can do to address the overall system of care. The better a job we can do when we use the water in our hand to not spill water when we have to hand it to the next clinical setting of care. As we get better as a system of connected settings, we get better at extinguishing the fire and preventing the fires wherever it is possible. We are all here from Array. This is not a promotional session, but we just do want to suggest areas where our capabilities may be relevant to the scenarios that we're demonstrating. We are a medical practice that has been providing timely access to crisis intervention and via telepsychiatry for over 2 decades. So let's get into it here. So let's say for a moment here, we have 2 bucket brigades, right? 2 lines set up. One line's pointing at community-based care. The other line's lined up with acute care in a hospital, both of which are experiencing this deficit of psychiatrists, this deficit of licensed social workers and counselors, this supply and demand imbalance. And so let's start first with the community. And so more often than not, patients are faced with or forced to make a decision on where and how do they access care. Is now the right time to access care? Certainly would never want to speak negatively to new resources and more resources. But the reality throughout COVID and coming out of the COVID era is that there are a lot of new options in this community-based marketplace. And while fragmentation is not a new concept in the behavioral health continuum, it has certainly been exacerbated by these new options. These new options spread our resources even more thin than they already were, and it causes confusion for patients, which compounds their difficulty in accessing care in a timely fashion, at a point where their disease state progression would be optimal to engage them in that care. So fragmentation and confusion is another compounding element here to the patient and to the system impact of accessing care at a point when their disease state would be appropriate to do so and optimal to do so. Now I'll turn your attention to the ED-initiated care. Now there's many pathways outside of, out of the ED, as is demonstrated on the right-hand side of the slide here, but it's rare for most communities to have all of those options available and accessible to them. And so again, we have a situation where patients leaving the ED are desperately needing this timely access and connection to the right, clinical care setting, the right clinician, the right mix of clinicians. But in reality, a lot of these patients may end up with a suboptimal decision, a defensive admission, if you will, where they end up at a higher level of care than is needed, or they end up at a suboptimal level of care, or worse, not even following through on engaging with care when they're leaving the ED. And so we're setting the stage here for a system that really has to be effective and efficient. And so thank you, Kara. We're putting a poll up here. I'm going to move past it on the slide here in a moment, but we want to hear from you. We want to hear how you rate the current state of behavioral health care services in your ED, how much of your ED volume is related to behavioral health. What, do you have specialized staff in the ED to manage these patients? What's the readmission rate look like, and the length of stay? So while you guys are doing the homework that we just gave you, let's face reality here. There aren't two bucket brigades. There's one bucket brigade, and we are all in it together. The buckets of water in this brigade pass through community care settings where there's smoke. They continue down the line to the ED where there's smoke, and they come back again to the community for post-acute services where there's smoke. And so when we break these down, let's first look upstream of the ED. We have the players and settings here. You have your primary care physicians, outpatient behavioral health, and virtual iterations of outpatient behavioral health, where the smoke is coming from insufficient clinical capacity, high demand, and constrained budgets, just to list a few. Move to the center of the slide here. Your EDs are also showing smoke from increased demand. Complexity and acuity of patients are also increasing. And, maybe too often, the ED is reaching to psych inpatient for a bucket of water. Those defensive admissions, where there's not enough water, there's not enough resource in the psych inpatient resources. Further, we need to reserve the psych inpatient resources for the patients who really need that care. And, I think the third element of consideration for why there's smoke in the ED is oftentimes we see EDs that feel ill-equipped to manage the patients while they're there, and maybe they pass that bucket of water on without fully utilizing it when they have that patient in their setting, instead waiting, sedating for that psych inpatient resource to materialize. And then the third part, post-acute care, downstream of the ED. The more effective that we can be at handing the water when the patient is being discharged from an ED, a medical floor psych inpatient unit, the less smoke that we have to manage when we're in the ED. And so here in post-acute care, we're looking to, relevant settings, depending on what the patient needs, depending on what the community resource allows for. It's namely IOP and PHP, step-down programs, primary care settings, and again, outpatient behavioral health or virtual outpatient behavioral health solutions. So for a moment, let's put our metaphor of the bucket brigade to the side and have some real conversation. Let's have some real talk about an honest look at these clinical settings. And let's look at these through the lens of optimal state and current state. When we talk current state, we're going to talk about clinical, operational, and financial implications of that current state. And then we're going to flip to optimal state and talk through realistic considerations of how to get to the optimal state and what are the positive implications when we do get there, when we make progress towards the optimal state. How does that have effects to the patient and to the system overall? And so let's jump in here to the current state when we're thinking about behavioral healthcare in the ED. And so, it's pretty standard that, most EDs tend to have the care being directed largely by the ED physician and the nursing team. In some cases, social work is there to help with case management. Maybe social work or LCSWs are being used for initial triage, but rarely you're seeing the social work, the LCSWs, engage in advancement of care, clinical intervention. In many cases, the care in the ED of behavioral health patients is more of triaging for a question of, do they meet criteria for inpatient placement or not? And that's not care, right? And it's no fault to the hospitals that can relate to that setting, but this is a current state where many of these hospitals, EDs, are ill-equipped to deploy the resources in a more optimal place. Oftentimes the triage, the evaluation doesn't actually ever reach the level of quantifying and identifying the risk factors of the patient, considering less restrictive levels of care, and considering how the care of the patient can be advanced while the patient is boarding. So where's the smoke? Back to the metaphor. I think length of stay is probably the first place that we're seeing smoke. It's the most apparent impact, right? Long lengths of stay for behavioral health patients is, unfortunately or fortunately, however you look at it, it's well known, it's well publicized nowadays. But what's less clear is the picture on what solutions are available and how will they affect this first factor of smoke, this length of stay. But we first have to consider, why is the behavioral health length of stay long? I think it fundamentally boils down to this continued sustained increase in demand, increase in complexity, and increase in acuity of behavioral health patients. And it's also related to insufficient psychiatric inpatient resources. That insufficiency of psychiatric inpatient resources is further exacerbated by defensive admissions. But the other contributing factors to behavioral health length of stay are dispositions that are set when the patient presents and are not challenged, not revisited, reevaluated as your nurses and your ED physicians change shifts once, twice, 3 times. Part of the reason why is they don't have access to specialty interventions, specialty clinician management. Psychiatrists aren't available, or if they are, they're in an outpatient practice or up on the inpatient psych floor, and their availability is delayed. It's morning and afternoon, maybe over lunch, or it's sparsely available. We also see screeners that in some cases can be unlicensed, really being asked to make a disposition recommendation or narrowly looking at admit versus discharge. And the reality of the length of stay is that on average, these behavioral health patients wait 14 hours longer in the ED than medical patients, which contributes to over $2,500 of increased cost per patient. We'll talk a little bit more about the financial implications, but before I hand it to Dr. Jamie, I want to challenge you to consider the patient perspectives of the patient ED. And it's clearly not a therapeutic environment for patients in crisis. It could certainly be detrimental to the patient that's there for behavioral health reasons or other medical patients. And majority of hospitals are forced into an intervention that is not therapeutic, rather it's risk focused. Sedate and wait for the patient to get inpatient placement. And so let me pause here and ask for Dr. Jamie to jump in here and share her clinical perspective on the current state of behavioral health management in ED.
Thank you, Scott. So as you mentioned, one of the things that we do know is that the ED, while technically it's considered safe, it's not a therapeutic environment in terms of typically not having daily access to therapists and groups, a lot of times lacking access to the basics like sunlight, generally not being a quiet and destimulating environment for people. And so with each moment that passes, patients may become less and less motivated for treatment and may have more and more anxiety or agitation. And then some people try to elope, and that places them at higher risk for potential harm from impulsive behaviors. So ultimately, this may lead to patients with concerning symptoms to be physically or chemically restrained to keep them in the ED. And this in turn may lend to more delays in assessment and treatment as the patient's just way too sedated to participate in a psychiatric interview to determine an appropriate disposition for them quickly. So we also have to think about the risks of side effects or complications from chemical restraint, like oversedation, potentially worsening the patient's baseline symptoms with the risk of them waking up more agitated, incitement of a dystonic reaction, blood pressure changes, and particularly low blood pressure, which can also lead to risk of falls. And besides the elderly, patients presenting with alcohol intoxication or requiring multiple sedative medications within a 60-minute period are at higher risk for these adverse events. With regard to impacts on medical care, there was a 2022 study in the British Medical Journal that came out of England that outlined how stays of greater than 5 hours in the ED for medical patients was associated with an increase in all-cause mortality within 30 days of that ED contact. So with similar studies internationally, today I could imagine that these numbers might be similar or in excess in US EDs, especially during and post-pandemic for people presenting for medical problems. So additionally, there was an American College of Emergency Physicians report from 2016 on ED crowding, and it outlines specifically how exceeded capacity can lead to delays in treatment, which leads to poorer patient outcomes. So having psychiatric patients boarding in the ED certainly can impose higher risks to patients presenting with acute medical illnesses. Then another consideration would be that without timely evaluation for psychiatric patients, there are patients who may not need to be admitted, as Scott had mentioned, that could otherwise be cleared for discharge from the ED, who are sent to inpatient psychiatric units. Examples of those patients might include someone with acute alcohol or other substance intoxication, or people who have ready connections to community resources who could have safe alternatives to admission otherwise. So obviously, this is creating further delays for behavioral health patients in need of who actually need the psychiatric beds and feeding into this backlog in the ED that we've been talking about. And Scott, if I may, we did receive a pre-submitted question that might apply here. And this question was specifically asking about how Array supports its clinicians who are not boarded in child and adolescent psychiatry to work with children and adolescents in the EDs. And so it's well known that we have an essential fire with the pediatric mental health crisis, which was essentially unmasked by the pandemic and formally declared in 2021 with a recent call to action with a joint policy statement from the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association. It was just released a few weeks ago. So our acute care service delivery model at Array is called on-demand care, and all of our clinicians see patients across the lifespan. And throughout the pandemic and beyond, we've been managing a larger number of pediatric patients in the range from 10 to 18% of our daily volume in our highest seasons. Usually it's a bit lower in the summertime for obvious reasons. So primary support for these patients and managing these patients is from clinical leaders such as myself who have extensive experience with routine and complex PEDS cases. And we also have about 30 to 40% of our physicians are child and adolescent boarded who work with us. So we also have a collaborative environment in which all of our clinicians have the ability to ask questions of their colleagues in real time and also provide lots of learning resources on management of those acute conditions. And thank you for that, allowing me that interlude, Scott.
Thanks, Dr. Jamie. And so back to the metaphor. So fire engines, tankers, firefighters, they're all expensive, right? But they're much less costly than delayed and incomplete intervention. And so we're still talking about the current state here, but I want to talk for a second here about tangible financial implications. What does all this cost? And so it kind of boils down into direct tangible costs, indirect costs, and kind of opportunity cost or opportunity revenue types of considerations. So, first, direct and tangible costs. The ED is the front door to the hospital. Throughput and length of stay are primary KPIs, if you will, for an ED for a reason, right? Because these are critical metrics in that pathway through the front door to the med surg department, kind of other hospital services, which are important, kind of accretive services to the hospital's margin, to their overall revenue, and kind of their revenue mix. And when you have patients clogging up the ED, that prevents bed turnover, it negatively affects throughput, which is core to this vital pathway. And more directly, patient boarding is not free, right? These patients consume resources, the attention of staff. It's affecting nurse-patient ratios, the cost to recruit and retain these clinicians. Patients consume meals, they use labs, there's sitter costs. There's a very real overhead allocation of actual expenses that studies suggest can be in excess of $2,000 for behavioral health patient boarding in the ED. Move next to the indirect cost, if you will. Think about the last conference you attended. Did you walk the exhibit floor? How many staffing agencies were out there? They're there because nurses have choices, physicians have choices in where they work, and they care about the quality of the care that they're delivering. And so when you think about an indirect cost of the current situation of how behavioral health care is managed in the ED, consider the indirect effect on attracting and keeping quality nurses and staff rather. And then the third element I would challenge you to consider is opportunity cost. The overall effects of a clogged ED with poor throughput contributes to patients left without being seen, patients leaving AMA. Hospitals put wait times for their ED on a billboard, right? Like if the ED is not open to your community in a timely fashion, patients leave. And those patients don't represent $0 revenue opportunity to the hospital. Rather, patients leaving without being seen or leaving AMA largely represent a missed med surg admission, which represents $8,000 on average of revenue to the hospital. And so a quick challenge before I move to the next slide. Run a report on your behavioral health demand running through your ED. Layer on top of that report the delta between your overall length of stay in your ED and your behavioral health length of stay. Add your overhead cost to it, attribute it to your left without being seen rate. Put that to one side. And then estimate your missed revenue opportunities and account for the reimbursement that you could get from delivering psychiatry, LCSW services, psych observation in the ED. Now what you have, if you follow my challenge, is frankly, I think it's a missing piece. It's a missing piece a lot of folks have when we engage with them. And it's the missing piece of the strategy that you developed and haven't executed, or you have been meaning to develop. Now you have the missing piece of that justification to seek partnerships with capabilities like Array is demonstrating here. And it gives you that missing piece of that motivation because you can do this. And so let's talk a little bit about what this is. And so acknowledge with me for a moment, this is optimal state, and it is possible. Just as there are closely followed standards of care for a heart attack or a stroke, there's a standard of care for behavioral health management in the ED. And so instead of passing the water, passing the bucket, fanning the smoke away, I would challenge you and encourage you to consider what can you do with the bucket and the water while the patient is there with you. And here's what you can do. You can deploy a team with the right mix, right clinicians, right capacity of clinicians to ensure timely and reliable access to specialty interventions. This optimal solution that we're discussing, it's not simply a staffing solution. This isn't more buckets. It's not even more water if you don't know where to point the hose. And so, we recommend, our perspective suggests that it's important that the team works through a model of care that is really designed to do a few things: collect and analyze and assemble kind of this data set of key foundational information and perspective to equip your clinicians for evaluation, disposition, treatment. An example here would be collecting collateral on every case, assessing access to lethal means on every case. Second, enable data-informed decisions for your clinicians. Quantify the presence of acuity, like risk factors or other complicating factors. I alluded to this earlier, is something that has had tremendous impact on our practice. But when you collect that data on presence of risk factors, that allows your medical leaders or our medical leaders to monitor clinician dispositions against the data set and work with those clinicians to ensure that they are equipped to make the most appropriate, least restrictive level of care determination for patients. Oftentimes, you'll find that these clinicians simply need, maybe it's better perspective on resource available in the community. Be proactive at advancing the care of your patients. The flame, back to the metaphor, the flame is at your feet. The patient is in your facility. The challenge is to use your resources effectively to advance the care of the patient. This is real optimal state stuff here. Engage with a team of psychiatrists if that's the right clinician level, who can do more than just rubber stamp admission decisions. That's an expensive resource to just confirm admission decisions. Use a team of psychiatrists to move that treatment decision and management to the specialty team, and encourage and require that team of psychiatrists to restart home meds, initiate stabilizing treatment, keep them involved throughout the course of the patient's stay, continuing to reevaluate risk, reevaluate the right disposition on the patient every day. And then also take a step beyond that and consider, what is the role of psychotherapy here? How can I bring crisis de-escalation, safety planning, maybe even family engagement to the patient's bedside? And what effect might that have on the patient and the overall system of care if we can do more with the patient while they're there with us? That's the system impact, right? The more that we can do to defer patients from psych inpatient and reserve those resources for patients who truly need them, the better a chance we have on unburdening the overall system. And obviously, psych inpatient is not the only one here. I'm just using that as an example. And one last point before I go back to Dr. Jamie on some rose-colored glasses of the clinical implications of an optimal state is case management. Your case managers are a vital resource, as is knowledge of community resources. That information needs to move upstream and be equipped with your team of psychiatrists, with your LCSWs, so that can help to inform disposition decisions. Farm that resource, farm your case managers when you're doing strategic planning. Jamie, clinical implications of the optimal state, if you will.
All right. So just to emphasize what Scott was mentioning, early intervention really is critical to being able to assess patients quickly and offer the most appropriate treatments. And so this is really important for patients who most acutely require that inpatient behavioral health admission. So part of the process that we particularly use is incorporation of measurement-based practices, such as scales like the PSS-3 or the patient safety screener. And it helps reduce the number of patients who are being admitted to behavioral health units who are low risk, who would otherwise qualify for a least restrictive lower level of care. And we also focus on ensuring that our documentation is supportive and follows and adheres to Joint Commission standards. So of course, collateral, as Scott had mentioned earlier, is another important piece of this puzzle, which really can aid in disposition determination. Have a couple of examples, but one in particular, I assessed a patient last month who came in acutely intoxicated due to substance misuse. And with his clinical improvement, I thought that he would be able to go home, but after speaking with his mom, it was extremely clear that he was a very high safety risk and required further treatment. And on the other hand, I've had a number of instances where patients come in from group homes who have psychiatric complaints, and they seek inpatient admission as a respite from going back to the group home, but getting additional information from their facilities is helps us to get our patients, discharged back safely to those facilities. So taking that extra step of obtaining the collateral, not just taking patients at face value, really makes a difference in terms of safety and appropriate resource utilization. From the standpoint of the second standpoint here, care plan initiation treatment, ultimate goal, of course, is again to get patients home the safest, most timely manner. And so having a collaborative care model where therapy is available really does help. I even had a patient this week where he had a debilitating anxiety disorder and came in suicidal. He had been in the ED for several days, and part of the concern from the patient's mom, who was providing some collateral about releasing him earlier, was that no one was talking to him to try to really understand the root of his symptoms. They're just giving him medications. And she was also, of course, concerned about some of the financial implications of what was going on as well, working extra shifts just to support him being able to get treatment. But he had additional support, working collaboratively with a social worker who's providing some therapy, some supportive therapy, and we are able to successfully discharge him with community resources. On the other hand of that, there beyond these financial implications of inpatient admission, there's that human impact, when patients are sent hours away and not able to, have family or friend support or loved one support. With regard to the third point here, and speaking of community resources, just providing an out-of-hospital disposition, it's just much easier when we have knowledge of available programs, whether it's going to be intensive outpatient, partial hospitalization, or substance use, or even a state level program. Interestingly, last month I had a patient who was unhoused and came in with a vague complaint of SI. And there was definitely concern that he was seeking inpatient admission for secondary gain due to the need for shelter. And he really didn't optimally benefit from prior inpatient admissions due to lack of participation on the unit and really just not adhering to follow-up recommendations. So he had no collateral, and by virtue of a few of his historical factors, he did carry some safety risk. But I got to talk to case management on site, found out there was a whole statewide program for frequent attenders of ED services, which offered temporary shelter via motel for a couple of days, some gift cards for supplies, in addition to case management services. And without that, I would have felt less confident in getting him discharged out. Thanks, Scott.
Great. Thank you, Dr. Jamie. This isn't all aspirational, right? We are very fortunate to have partnerships where we get to see hundreds of real-world examples like this, where a hospital makes a plan, looks to a partnership approach to fill some capabilities and execute the strategy. Usually we share case studies with 12, 24 months of data. This is 3.5 months, 2.5 months rather, of data from an implementation where we saw really tremendous impacts from the start. Real significant drop in length of stay, significant drop in admission and reliance on psych inpatient resources. The time to consult when we're looking at ED and med floor drops significantly, has continued to improve in timeliness as well as disposition. And so it's time for homework and audience poll number 2. And so we will share the results of this at the beginning of the Q&A section at the end, if I can talk fast enough. And so we want to hear from you. What % of your behavioral health patients are recommended inpatient psych as opposed to discharge to the community? And HEDIS, is that a difficult measure to hit in connecting patients with care upon discharge of the ED? And with the HEDIS question, we pivot back to our bucket brigade here, right? And so I'm taking some liberties with the metaphor, but let's talk upstream and downstream of the ED. And really what we're talking about here is preventing the fire and keeping it extinguished. When we think upstream of the ED, we find a patient in the community. Maybe they're engaged with their PCP, maybe they're engaged with outpatient behavioral health, or maybe this is a patient who is not yet engaged in the care, under the care of a clinician, and they're seeking access to care. Downstream of the ED, downstream of the med floor, downstream of psych inpatient, we find a patient who has found some degree of stability after having decompensated, and they need to be engaged with, or they're already engaged with a step-down program like PHP, IOP. They're engaged with outpatient or similar resources. What's the current state here upstream and downstream of the ED? I think we've done an excellent job as a nation, as a community of behavioral health stakeholders in increasing awareness, reducing stigma for behavioral health. And that has certainly contributed to what we've seen, which is increased demand. More people are aware of what to look for when they're looking for smoke, looking for the fire. And we have prevalent resources for education and screening. But keep in mind, this is occurring in a fragmented and confusing system. We also have non-firefighters, if you will, doing a lot of the work, right? You know, bless our PCPs, but patients are backing up into PCP caseloads. They're getting stuck there because referral options aren't available. And many of these PCPs have a high degree of discomfort in diagnosing or treating high acuity or persistent behavioral health conditions. Limited water, right? Supply and demand imbalance. You know, we're seeing long wait times, high travel distance for patients waiting for new appointments, tight budgets, insufficient reimbursement. Let's call it how it is, right? This is, you know, behavioral health is rarely revenue positive when you're looking at unit economics. Resources are stretched thin. You know, many of our partners, hospitals, health systems, safety net clinics are under tremendous financial strain because fee-for-service reimbursement is not easy, and there's insufficient state funding. And so the challenge here is, so what, right? I mean, patient care is delayed because of poor access. The fire smolders, and it sparks in the ED. You know, what we have is a line that becomes divided. You know, our bucket brigade line, water becomes spilled. You know, handoffs become difficult. There's a longer reach for handoffs. And patients get confused, get frustrated, and patients get dropped. Siloed care also contributes to our ability to maximize the impact. Siloed care can cause us to not have as high a return or use of our resources. Dr. Leroy, can you please share with us some clinical implications of the current state?
Sure. So as Scott was saying, you know, it's great that we've reduced stigma and increased awareness, but now we have a lot more patients, and all these patients are going down this path that is a confusing path for them. For a lot of them, it's the first time going down the path. So we need to do what we can to reduce barriers and obstacles to these patients that are engaging in care. Because what does happen a lot of times is, you know, a patient might end up thinking, okay, I just have to deal with my depression or my anxiety or ADHD because I just don't know where to go. Or a scenario might be that a patient has gone to their primary care doctor and they have the courage to speak and have a constructive conversation with their primary care doctor. And they might say to their primary care doctor, I've been doing some screeners online and I think that I've been feeling depressed. So now the primary care doctor talks to the patient and assesses that, yes, this patient is probably going through a first episode of a major depressive disorder. And it depends on the PCP how they might manage that. Some of them might be able to start a first-line SSRI for that major depressive disorder. But in the midst of everything that is going on in a PCP clinic, it's not going to necessarily start the cascade of treatment that we would want that would be optimal state, which would be things like tailoring in therapy. And then when you think about, you know, just because the PCP is able to prescribe an SSRI, that may not be what's needed for all patients. How does that PCP monitor side effects and response to treatment? How does that PCP that has limited time with patients deal with the patient who isn't getting better, and that patient might be dealing with treatment-resistant depression or an evolving bipolarity? So at this point, the patient's not getting better. The doctor's still trying to help, but you know, if the patient's not doing better, then they potentially can continue to experience symptoms that impact their daily functioning. And I see this, you know, frequently whenever I'm treating patients where the PCP has started care, and by the time that maybe the patient and the PCP have had discussions, and this patient has tried one or two different medications, but has not had a clinical response. And then when they come to me and we are able to do a full psychiatric assessment, I've been able to potentially consider that there is bipolarity. But by this point, the clinical implication has been that because the patient had not gotten any better, there are real life consequences. We think about a patient losing productivity and not being able to, go to work, and also consequences with their relationships, like romantic, social relationships. I have examples of people losing a relationship, breakups, because mood swings are too severe, and it has to come to that situation where the relationship ends, and then that can force the patient into getting psychiatric treatment. Then when we think about clinical implications, the safety net clinics like FQHCs, we know that these systems are overwhelmed. And I'm speaking from firsthand here. I worked at the Federally Qualified Healthcare Center for many years in Austin, Texas, before I came to Array. And in Array, I still deal with FQHCs through telehealth, through the work here at Array. These FQHCs are critically important, but the reality is, like we've said, that these patients are being turned away, or there may not be optimal appointment cadence because the resources are being stretched. And so again, the patient might be turned away. They find out that their next appointment won't be for 3 months, and that appointment may not even be with a psychiatrist. It could be with a therapist. There are, again, clinical implications to that. So symptoms continue. Patient will have self-isolation from friends, family, miss work days due to the depression or the anxiety, with the accompanied loss of income, and then ongoing self-neglect, less adherence to their hypertension or diabetic medications, leading to worsening of medical conditions. So when we think about this, we have PCPs and hospitals as the face of healthcare for a lot of patients. Patients will turn to their PCP or a hospital setting to get help navigating the systems. And when a patient has had a good experience and feels connected with their hospital, they will look for outpatient services in that system. I have examples of this where we work with highly known entities in different states, and sometimes patients have come to us saying, even though I was at this particular agency, they don't have psychiatry, but patients are telling us like that's where I looked first. And then to expand a little bit on the point that Scott made, there are handoffs there are problems with handoffs in the points of care in the silos that are the points of care. And so you think about a patient that might have started seeing somebody when they were employed, they started to see a private practice psychiatrist. And then something happens, they lose their job, and now they're on Medicaid, and they might be seeing somebody in a community mental health center. So these systems are not talking to each other, and this is a disadvantage to patients. Patients feel like they have to start over again. They see this the patient sees this fragmentation, and it leads to demoralization and amotivation about their care. So we definitely have to think about how we can improve this continuity of care, because it doesn't have to be like this. We can do better for our patients.
Absolutely. So let's set some of this aside so that we can see more clearly. Like, set aside supply and demand balance, siloed care, financial constraints. Let's look at how we can build a better machine, a more effective and efficient bucket brigade. And so I think the guiding star here that we aspire towards is the right care, the right time, and the right place for every patient, reducing barriers to care, providing complete care, doing so efficiently, with the right clinician mix, practicing at the top of license, right? So kind of back to our metaphor, the idea here is, design a system to identify areas of risk of fire. Identify ways that we can get to patients, prevent them from progressing from mild to moderate to acute, because we've spent the time evaluating the need. We've built care pathways for specific patients to tailor their care. And what does success look like? I think success looks like patients who, less patients are languishing with latent or even no needs, and less patients endure the trauma of an ED visit or an inpatient stay. And so if you look to the bottom of the slide here, let's buzz through some of what optimal, what good looks like in these 4 settings. So first, PCPs. We have got to all get on board with collaborative care or similar structures. We must find ways to support PCPs with consultation, with behavioral health care management, advice on diagnosis and treatment. And there are models out there. There are payer structures out there that make a ton of sense for supporting our PCPs. Remember, from a system perspective, when we do this right, PCPs comfortably manage a higher percent of the behavioral health need in the community, leaving more capacity in outpatient behavioral health with patients with higher acuity, higher complexity of condition. Second, let's optimize the care that we're delivering in outpatient behavioral health. A challenge, how long has it been since you've updated your policies, your procedures, your clinical algorithm, if you will? Was it COVID? Was it before COVID? During COVID? We can't afford a cookie cutter approach to outpatient behavioral health. We really need to consider and adopt digital strategies to engage patients and tools to do so. We need to challenge a cookie cutter approach to outpatient behavioral health and reconsider how you're using your clinician mix to meet the patient's needs. Consider, is it appropriate for every patient to see a therapist for intake before a psychiatrist? Move away from one size fits all approaches if it's not working. And maybe appointment cadence is something to look at. Does therapy need to be every week? Does med management need to be once a month, every 3 months, what have you? And I would challenge you to create care pathways tailored to the patients, tailored to their needs, so that we get to a point where outpatient behavioral health is providing efficient and effective care in a way that is financially sustainable. And I think part of that is allowing the PCPs to more comfortably manage part of that patient population, so outpatient behavioral health can be optimized for a higher acuity or complexity patient population. Third, let's not let virtual outpatient behavioral health add to the fragmentation of care. When we built Array at Home, the first tenet that we built it upon was providing patients with the experience that they expect and deserve when they're seeing a clinician in person. The second tenet we built it upon was behavioral health will no longer be the black hole of referrals. And we've stayed true to that, right? This practice is built to be proactive at, and thorough at communicating with referring parties. We're really proactive at trying to engage in getting with PCPs to get more of a longitudinal view of the patient journey, being proactive in engaging with payers to find out benefits and eligibility and maximizing the care within that benefit. There are ways to bring virtual outpatient behavioral health options like Array at Home back into the mix so that it doesn't represent confusion or fragmentation. And it can be, in some cases, a preferred model of care for some patients, but not all patients. And can be in the line of the Bucket Brigade. Fourth, PHP IOP, thank you if you've invested in that. Please continue to look to what your community needs in step-down programs. Start by analyzing the needs of your community. Have conversations with stakeholders that have engaged or will engage with that level of care. And don't assume that if you build it, they will come. And if your enrollment is below where you want it to be, invest your time and resource there. Engage the stakeholders whose own processes, whose own Bucket Brigade, whose own fire can be helped by engaging with step-down programs, and do the math. Score patients when they're coming in and demonstrate the value of the care that you're delivering with step-down programs. Before I pass it back to Leroy for a more rosy colored outlook on the optimal state, I just want to comment that hospitals are really in an optimal state to benefit financially from investment of care upstream and downstream of the ED. And the reason is because the ancillary benefits of opening up this capacity to patients earlier in their disease state progression, and the ancillary benefits from reducing the burden outside, pathways out of the ED, directly benefits your financial picture in the ED, in your med floor, preventing patients from overstaying their DRG. if you have a psych unit, and ensuring patients are more optimally cared there. And so I would encourage you, and I will here again in a second, to consider the financial benefit, not just to an outpatient behavioral health program, but to all the other areas that are positively affected. Dr. Leroy.
So I'll speak briefly to it. When we think about the optimal state here, and expanding on my prior comments. So in the optimal state, if a patient has gone to their doctor for a flu shot or a physical or blood pressure management, if that patient does bring up depression, then that PCP would be able to know that if they did start treatment, that there would also be an avenue to potentially, or if needed, refer that patient to somebody like therapy and psychiatry. And array would be one option, but we're trying to keep this kind of bigger picture. But I think that when we think about that, there's a lot more comfort that a PCP will have whenever they are starting that sort of treatment, because they know that they'll be able to pass it along if needed. Instead of getting back to like the current state where it's like not everybody knows how it's all going to work in terms of passing things off. And when we just think about the community benefits, we're going to have less ER visits related to mental health visits, improve patient outcomes, including, beyond the things that we measure clinically, but just thinking about patient life satisfaction, work satisfaction. So we think that there's a lot of opportunity for hospitals to, invest in outpatient behavioral health resources and PHP and IOP programs so that they can affect clinical outcomes.
Thanks, Dr. Leroy. I want to try and get through our final slide here, maybe in enough time to see our results from our polls. But just to pull it all together here briefly, the solution here is a team effort. As we do a better job of managing patients and utilizing and leveraging the resources that we have in our hands, when the patient is there in our facility, it unburdens the rest of the system. And so that's my overarching challenge to you, is consider how you can do more with your limited resources with your role in the Bucket Brigade. And I would challenge you to converge stakeholders to have conversations about, tell other stakeholders in your community, here's what I'm equipped to do. Here's how to engage with me. Here's my mid and long-term plans and my trajectory, and ask the same of them. And as you're building a strategy, dealing with the fires right now and then building a strategy for mid to long term, I would encourage you to broaden your ROI perspective. Really move away from unit economics and consider the financial opportunity and the current financial implications of how you're doing it right now, and incorporate that into justification for investment and capabilities. There was a lot more I intended to share there, but hopefully we did what we intended, which was to share strategies for getting beyond the Bucket Brigade as we move through the presentation. Rhonda, what do we have?
Well, I think our audience would love to see the results of those polls. We have just a couple minutes left, so if we have those polls ready to roll, we can throw those up and let our audience take a look. Okay. Scott, do you want to address that at all? You've got like 1 minute, but
I'd say half of patients, or half of the attendees would rather see better care in their ED. Frankly, seeing a high percentage of behavioral health patients coming to the ED, and just more than half do have specialized staff, which is good. They can act upon some of this, but readmission can be an issue. Length of stay of more than 15 hours is a common response as well. And so that's poll one. Poll two. We do see a high incidence of admission in inpatient psych. We see a lot of folks having issues connecting with care after the fact. I think that proves some relevance here. So thank you all for engaging in the polls. That's helpful.
Yes, and thank you for attending today's webinar. I want to remind you that you do have access to the slides. There's some incredibly great information on the slides. So those that we weren't able to get to today, really want to encourage you to look back over the whole deck. if you did not, well, obviously you did not. We didn't get time for question and answer today, which is just fine. We will follow up with you all and try and address your questions on a one-on-one basis as much as we can. So thank you again to all of our presenters today for an excellent presentation, very timely, and we look forward to maybe hearing from you again in the future. So thank you again, everyone, for joining us, and have a great rest of your day.
Thank you all.